pregnancy is like a journey. Nobody expected that you will end up an accident. But if the accident happens, you need to
should be prepared.
You should be prepared for everything. If suppose somebody is expecting a premature baby, we go and talk to the parents and explain them what they are expecting. We prepare them what is going to happen, so that there's a lot happening when the baby is born, and it's very scary for the parents. I think it's important to be prepared. The smallest baby I have managed is actually 22 plus 6, so one day before the viability, but we supported because the parents were very keen. This was 15 years ago, and that child is actually 15 years now. I'm following him on Facebook. Managing these such babies is an art, and it's a teamwork.
This is such a complex effort, and the entire team it's like that Formula 1 car comes in, and then the whole team has to work in unison to make sure things happen right.
I mean, this is a very different field, wherein technology and nature, come together.
One thing, from the stories which come out is positive approach for the parents. So some of the parents don't want to give up. They want to give it everything. They want to try it to the last breath. And I've seen the babies turn around, and there are things which are beyond, there's a nature and the God who decides the fate of the baby. Positive from parents and positive effort from the doctors, then definitely the wonders will be made, and I have seen that happening many times. Parents hand over the baby in our care, so it becomes my baby till the baby is discharged, so we want to make sure the baby goes home.
So you are the guardian of the baby.
Yes, for that time period.
So the neonatologist is the guardian of the baby in the ICU.
Right. Correct.
So welcome to Medicast podcast, and today we have Dr. Kiran More. He is one of the leading neonatologists in the city. He has the distinction of working in all the continents of the world, and he's also worked in all the top 5 children's hospitals in the world. He was head of department of Wadia Children's Hospital, and now he's a head of department in MRR Hospital, which is in collaboration with Sick Kids Canada, one of the premium children's hospitals in the city. Welcome, Kiran. Welcome to Medicast podcast.
Thank you, Uncle.
Awesome. I mean, it sounds so amazing. Some Sick Kids is coming to India, and you are collaborating as a chief of neonatology. Sounds amazing. But Kiran, just for everybody, I mean, what is a neonatologist? I mean, how are you different from a pediatrician? How do people know that what work you are doing different from a pediatrician?
Perfect. Thank you for asking this question. And often, this differentiation is not known to many, to our surprise. And in fact, the neonatology as a specialty has been established for last 20 years. There's like a separate 3 years program for it. Okay. So newborns are basically focusing on the first 28 days of life. And that's the period which is most fragile and most crucial period of life, which makes the foundation for the future life. And why this specialty has separately identified, because newborns are not miniature adult and they are not even miniature child. So the physiology is very different, because there's a lot going on at the time of the delivery. So they are sort of transitioning. There are a lot of unexpected things, and there are a lot of surprises which can come at the time, and that's why they need a more crucial and very intense care at the time. So that's why it's a specialty.
Okay,
it's wonderful you say that that neonates are not miniature adults. That means their physiology is different.
Absolutely.
That means the way a doctor sees an adult, the same doctors cannot treat a neonate, right?
Absolutely.
Right. So we understand it's a very vulnerable period, and the child is growing. The first 1,000 days concept, which we all know, which is the foundation of how things will shape up in the future.
Correct.
First 1,000 days of life. Just want to ask you this: in neonates, what are the diseases specifically seen which you don't see in pediatrics or grown-up children?
So there's a whole spectrum and gamut of the diseases which newborns can present with. But a lot of the things which are unique to newborns is the disease they encounter during the transition from mother's womb to the extrauterine life. So when they're born, a lot of things can go wrong. So either they might born prematurely too early when they are not ready to be born, or sometimes babies don't cry at the time of birth and then they suffer a lot of brain injury or something like that. Many times they are born with some heart disease or conditions which require surgery at the time of the birth, which is again unique to the newborn period as well. And again, these babies are very immunocompromised, so they can get a lot of serious infection and they can succumb very soon if it goes undetected. And there are a lot of unknown conditions, genetic conditions, which can, there are a whole gamut of conditions babies can born and they present in the newborn period, and there may not be appropriate signs, and they need like a lot of advanced investigation to diagnose that.
So basically, if you do a normal pediatrics, like an MD pediatrics, you need to train further to be able to manage such small young kids, you know, less than 28 day kids, you know. So
Correct.
you train separately for that?
Yes, absolutely. I think, most of the pediatrician can manage newborn who are stable and, or they need some little bit of help, sometime in breathing or feeding and all those things. But when it goes to little advanced diseases, the babies are very sick. They have issues with dropping in the blood pressure, they need ventilator or breathing machine support, or they're born too premature, then that becomes like a very niche area where you need a specialized training, an extended training. You need a team which is specialized and trained for doing this babies and manage these babies round the clock. And that's why it's almost like a good 3 years training is minimum required for somebody to get very much specialized in this field.
So, Kiran, we always say the babies need to cry, right? Why should a baby cry? And what are the things what happens, when the baby cries? And is there a problem if the baby doesn't cry? And what is the time limit till which the baby, if the baby doesn't cry, there might be implications for it?
Correct. So it's a good question. So baby's cry sort of marks the transition. So when the baby is actually inside the mom's tummy, baby is floating in a fluid, and baby is not crying or not even breathing for that matter, and all the nutrition of the baby is taken care by the mother, and baby floats nicely in the in that tummy. And when the baby is born, delivered, the first thing baby needs to do is to cry, and that does a lot of things. First is to push this whole fluid out of the lungs, and babies take a first breath because the baby cries, and the first thing he does after crying is to take a deep breath. It pushes the fluid out of the lungs, so it helps the baby to sort of open up the lungs and establish breathing. The second thing which happens, the babies cut from the mother's attachment, which is the umbilical cord. So then whole transition, the onus of the breathing and the circulation of the blood comes to the baby. So baby has to be very vigorous to do that. So breathing plus maintaining the whole circulation in the body, and for that baby needs to cry. Also, if the baby don't cry, and not only the breathing effort is affected, but also baby's consciousness level can get affected, so breathing can get paused, so baby needs to again woken up. So that's why a lot of time you might have seen the video, the first effort everyone takes to
you stimulate you hit the baby.
Or hit the baby.
Do you really do that, like upside down and hitting?
That very famous
video, I
scene
know.
from 3 Idiots. I remember Amir Khan hitting
hitting the baby.
So is it that like that, or it's too dramatic?
I know. I mean, all is well doesn't work all the time. but idea is basically baby needs to wake up so that the brain sends signal to breathe, and it sends appropriate signal to for the all organs to kick start, and the breathing has to be established. That's why it's a very important is the event. Now beating
So very nice word used, kickstart. So it's like a kickstart.
It's not a kickstart, but you don't have to kick a baby to start the life.
just to taking from Ankur's question on why should a baby cry? So what if the baby doesn't cry? Then how do you deal with it? Because I think, we've seen those movies and all, but then how do you actually deal with it?
Correct. So I think this is a very sort of a bigger scale problem which is happening in India, and it goes unnoticed and unmanaged many times still, and it's a sad state of reality even in Mumbai, that obviously when babies don't cry, many times the pediatrician or the neonatologist go sometime there and try to help the babies, and after some effort the babies do establish breathing, and these babies do get support. But what can we do to protect this brain? That is where the crux lies about how these babies will do better. So obviously, first thing, as I said, managing them at the time of the delivery. Actually, it starts before the delivery many times. So obviously, monitoring of these mothers, where these babies might be struggling inside, their heart rate sometimes drops, or there are different babies activity goes down, the kicking is less, like the baby is not moving much. The mother will know there is something going wrong in the inside the tummy, so she realizes, she senses it. So that has to be taken care of, and attention has to be given. Many times there is a delay in delivering these babies, and most of the gynecologists will address it very quickly. But then if, for God's sake, even 5 to 10 minutes that baby doesn't get enough blood circulation to the brain will suffer the asphyxia, what we call, or lack of oxygen. Now, how do you protect that brain? So what we do is, and what is worldwide practice, and it is only practiced very few centers in India and in Mumbai also, that we cool them down. So how do you protect the brain is by decreasing the brain's activity. So when you cool down the temperature by almost 3.5 degrees, the whole body activity goes down, including the brain activity, the heart activity, all the body organs activities go down. And we put them in a cooling sort of blanket for 72 hours and then monitor them very strictly. Many times they are on the breathing support. We monitor their heart function, and we monitor their urine and everything, so that we give her adequate care, so that one damage has occurred, but at least the further damage is prevented. And when the brain activity goes down, because there's a lot of sort of chemicals which get released because of this activity.
At one point you want a warmer to keep the body temperature right.
Yes, but in this case we want a baby to get controlled low temperature, but one cannot do it ad hoc. So we need a special machine which will control the temperature exactly in that temperature range, because if it goes too low, that will damage a lot of organs. If it fluctuates too much, that will damage the brain. So we actually control them around 33.5 degrees for 72 hours. We monitor their brain waves, because the brain, there is a lot going on in the brain, a lot of chemicals are released, so they can have fits, they can have slowing of the brain. So we put them on the video EEG, so we monitor their activity, we monitor their brain waves, and if there are seizures which are picked up on the video, we give the medicine so that it doesn't damage the seizures is like fits, so fits should be controlled so that it doesn't damage the further the brain further. And that has shown quite remarkable results. So I have followed a lot of my babies who looked really in bad shape at the time of delivery, but they done well. At the 1 year or 2 year, the development was pretty good. Obviously they get some development delay, but if you don't do that, you don't support them, then obviously the damage is done, and you further damage them because you don't monitor them for next 3-4 days, which is very much required. So they needs to be referred to the center who can do this, which is like we have currently at MRR, we offer this cooling therapy, which is again not known. And unfortunately, I was talking to a few of the gynecologists, they are still not aware of such therapy exists. And I have been cooling from year 2007 or 8. Now it's almost 15-16 years that we have been cooling. We're cooling at Wadia as well. And so there are only few centers which are doing it. So parents probably should take the baby to a place where the cooling is offered.
I think reinforce what you are saying. That means whenever the mother is delivering a child in any hospital, you have to have a pediatrician or a neonatologist around to make sure that this step is taken care of, and you're not missing out on this crucial step, isn't it?
Correct. So ideally, yes, because you don't know at what stage things might go wrong. So what WHO, the World Health Organization, recommends a trained person who can actually resuscitate the baby. What does that mean? If things goes wrong, if they will be able to support the breathing, or even put the breathing pipe inside to stimulate and help the baby if they don't need. So that's why there's a big campaign called as Helping Babies Breathe. So we train a lot of the paramedics also, like the nurses also, to do that. But in an ideal situation, you need a fully trained person who can do everything for the baby at the time of the delivery if the things go wrong. So a trained person or a pediatrician or a preferably neonatologist is required.
Right.
So a lot of young people watch our podcast, and young couples also watch it just for their sake. So if suppose my wife wants to deliver, so what are the things I need to look out for? A, in a doctor, and B, the team, and C, in the hospital. So what are the things which I should see for before I choose a particular doctor, a particular team, and a particular hospital?
Okay, good. So, I mean, it's a very valid question, and a lot of young parents do face that. So, see, delivery process, now there are two stakeholders important. One is mother and one is baby. So, safety of both of them is utmost important. So, you have to be in a hospital where both are safe, and if there is things go wrong, mother should be taken care of and the baby should be taken care of. Now I'll focus on talking about the baby, that okay, so there has to be facilities for resuscitation available. So there should be a basic minimum setup where babies can be supported, so like having a basic warmer, and to support the breathing there has to be a backup of a ventilator if required, or some kind of a breathing device which will transition. In an ideal scenario, if you want to choose, especially when there is a high risk, it's very, see, every pregnancy is precious, but if you are a precious pregnancy or somebody delivering prematurely.
Sure. What do you mean by precious pregnancy? Like, as you said, every pregnancy is precious. So, is there a definition to say?
Correct. So there are so there are certain things. Sometime on the antenatal scan, there are some red flags which gynecology will tell you that okay, we might expect some things might go wrong. A baby is not growing very well. There is a chance that baby might deliver prematurely. Baby is born by IVF conception, so in vitro fertilization, and the rates of
It's going up like
crazy. So you have a baby, having a baby after 5-10 years of a marriage, and it's a very precious baby. You want everything to go perfect. So at that time, you should deliver a baby where the support of an NICU is there and a good NICU is there, so that they can manage not only the basic thing but even if advanced things are required. And but obviously there are very limited places like that, so then at least the neonatologist should be there at the time of the delivery, who can stabilize and make an appropriate transfer to the a good NICU backup if the situation arises.
Okay.
Many times the things go well and babies do cry on their own and things transition well, but you have to be prepared like for everything. So ideally a good setup with a good NICU backup. Now, what do you mean by good NICU is, there comes the good infrastructure, so you should have got appropriate advanced equipment there. You should have a good team of doctors and nurses led by a good sort of a leader who's a neonatologist, who knows exactly what is ideally required for the care. It's not only the equipment, it is the whole sort of a combination of the good team supported by the good infrastructure which is required. And then you can be assured that your baby will be taken care of.
So let me summarize this. So what you're saying is, I should not only focus on the gynecologist. I should also ask relevant question as to who is your neonatologist.
Correct.
Where is this neonatologist attached, and which NICU backup is there.
Correct.
Plus also, I think you're not focused on the mother. Being a cardiologist and an intensive care specialist,
Correct.
I can tell you things can go south even with the female, with mother. You also need to ask about this as to, do you have a medical ICU or a medical doctor or a physician,
If the
who's
mother
there in the
gets sick,
backup.
suddenly there is a bleeding can happen.
No, like PPH happens, we immediately have to rush and embolize at
You
that time.
do that,
Yes.
right? You are there. You are the
Yeah,
specialist.
lot of times
So what do
we
you do that if the mother
so in
bleeds?
fact, a lot of times, as you mentioned, precious pregnancies, we know there are sometimes some placental abnormalities, low placed placentas.
Placenta, what is placenta? If you can
Placenta
explain to
is
us.
where exactly you get all the nutrition from the uterus to through the uterus to the baby, and that's when sometimes it's stuck to the uterus, and generally after the delivery the placenta would separate out and come out.
Correct.
Unfortunately, sometimes it cannot, and it might
Yes.
massively bleed.
Absolutely.
And may be associated with a lot of severe postpartum hemorrhage, and at that time we come in, embolize, block the blood flow, and most importantly save the uterus from removing at that time.
Right.
So what is called as obstetric hysterectomy, and you prevent that because you want to make sure that it's available for a next
pregnancy also.
Right,
So
right.
it's mother's life, also the safety of the uterus, and also you need a blood bank. So you rightly pointed,
Exactly,
blood
blood
bank
bank.
backup has to be
I know,
there.
I know.
So in case of emergency, you need to pump
I
in
know.
the blood.
Wow,
So-
so many
so
things.
I
There's
know,
so
I
many
know.
things.
Yeah.
I mean, I don't think so. People think like this,
No,
and I think
yeah.
from our podcast, people should be.
I think I never thought during when Shaurya was born whether there's a blood bank actually available there in the center at all or not. We never thought like that.
So exactly, I mean, see, pregnancy is like a journey. You plan. Nobody expect that you will end up an accident. But if the accident happens, you need to
You
have
should
a
be
backup.
prepared.
You should be prepared for everything.
Okay.
That's how everyone should think of the. Obviously, everyone expect the best case scenario, but you should be prepared for the worst
Okay,
case.
so Kiran, just to add to what you're saying, you mentioned a word called premature babies, and that's where you have a very, very vital role to take care of them.
Correct.
So how early is considered early, and when it is becoming difficult for you to manage? So what's the earliest or the youngest child you've handled?
So because I have worked almost 13 years in outside India, so the field, the neonatology is little advanced compared to India in some Western worlds. India is definitely catching up, and we are not very much behind. But there the cutoff was around 23 weeks. So normal pregnancy 9 months is around 40 weeks, and we used to manage all the babies beyond 23 weeks. For all of them, we used to.
So viability was 23
So
weeks.
viability was considered 23 weeks, and
So
now
that
Japan,
means a baby less than 23, they would not
they would
consider
not do
that
anything. Yeah, they will
right?
not touch. They will not offer any resuscitation. Now Japanese have pushed it further to 21 weeks.
Oh.
We have not, and not even Australia,
Oh.
New Zealand, and Canada.
So what would be an
That's true.
average baby weight in 21 weeks?
So it will be around 400 to 500, around 500 grams.
Oh
So
my.
most of, so
500
is like,
grams would
yeah,
be-
little more weight than my mobile. So and the size will be like that only. It will fit on my palm. What the equipments we have currently, 500 grams and above or 450 grams and above, we can manage. So smallest baby I have managed is actually 22 plus 6. So one day before the viability, and we again debated whether we should support or not, but we supported because the parents were very keen, and that was in Australia. Now this was 15 years ago, and that child is actually 15 years now.
Oh my,
I'm
oh
following
my.
him on Facebook because now I'm not in Australia, but that baby is doing pretty well because the parents proudly post his
Pictures.
achievements and pictures
Wow.
in his school and all. He had a little bit of refraction issue. He was slightly slow to begin with, but then he
I
caught
think
up.
you are a half parent for that kid,
Yeah,
giving
because-
complete life.
Because these kids spend like 3 months with us, so we get equally attached as the parents because we tend to spend a lot of time with them.
Absolutely,
So I mean, again, so managing these such babies is an art, and it's a teamwork. Not an individual person can do it, because what we are trying to do is we are trying to simulate what nature does automatically. So when the baby is inside mom's tummy, all these things happen automatically. The mother is working, she doesn't realize. But if the baby comes out, it becomes a nightmare because nobody is prepared for it. And what happens is, like, we try to emulate or simulate like mother's womb like environment. So as I was mentioning, the baby is nicely floating in the mother's tummy. So when baby comes out, he suddenly gets exposed to a lot of noise, the environmental exposures and all those things. Baby tend to get cold. So what we have specialized these incubators where we keep like a moist humidified air, so that the baby is well protected, and the skin is very fragile, so they will tend to lose a lot of heat from the skin. So we protect them inside. We put a lot of humidity there. Luckily Bombay has a lot of humidity, so but we put such humidity, so you feel like you are
You simulate mother's womb.
Yeah, simulate mother's womb. And then that incubator is packed nicely, so there is less noise, less disturbance. We tend not to touch them. Then obviously to feed them, babies are not ready. Feeding comes later. The first thing is they are not ready to take breath. So their breathing needs to be supported. They forget to breathe because the brain is not mature. Brain doesn't give signal. So then we give them some medicine like coffee. The caffeine we give them to stimulate the brain. Like we all need coffee in the morning, right? So we give the coffee in the form of caffeine to the baby so that they don't forget to breathe. But then obviously they need to be supported on the breathing machine. So we put them on ventilator for a few weeks till they are ready to breathe on their own.
But wondering, nature is so powerful.
Yeah.
I mean, when you said mother
I know,
goes about
I-
doing the activities,
Exactly.
it's so resilient,
Exactly.
And it's like an NICU walking,
Walking in ICU, automatically things are happening because when we try to do that, it's not easy. So we do exactly the same. So the umbilical cord is attached to the mother's placenta so when we cut that cord, we put the lines inside that cord only. So and we, instead of the placenta, which is the mother's organ which supports the nutrition, we connect it to the bags which has got all the nutrients. Those are the TPN bag, total parental nutrition. So whatever the baby needs, we will pack that in the bags and then give them through this belly buttons, umbilicus.
Okay.
And then we do that for period 7 to 10 days, and then we start them on feeds because the baby's tummy is also not ready for accepting the feed. So slowly we build up with the mother, and we try to give only mother's milk.
Yeah.
And then because even the heart is very weak, heart needs sometimes support. The blood pressure drops or it goes up. You have to control the blood pressure. And it's very challenging. So imagine 500 grams baby, their vessels are also very tiny.
That's
size
what
of
I
the-
imagine. How do you put lines?
IV
over-
lines.
So IV lines. So as I said, sometimes we start with the umbilical lines. So we put the lines in the belly button. They are slightly bigger, but the other lines are as size of my hair. So we put lines inside that hair, one French line, which goes into the heart and then stays for 2 weeks. so that we don't prick them often.
Wow.
And
Wow.
so it is actually, you can see,
I
very
think the
challenging.
unsung heroes, I mean, obviously the doctors are, the Kiran Mores of the world are there, but also I somewhere feel the unsung heroes are the nurses.
Yeah,
Absolutely,
absolutely.
absolutely.
I mean, neonatal nursing is a different ball game,
Yeah.
Absolutely.
Nursing these kids, I think doctor is there. Obviously, he manages the parameters, he gives orders, but in the end, the execution, the nurse stays throughout with the baby.
Yeah.
So nurses are the champion, as you rightly said, and that's why I said the best NICU is the NICU where the best team is there, which is not only doctor but the good trained nurses. So we do focus a lot on training these nurses, because it's not easy. Again, not an adult trainer or a pediatric trainer also will be able to manage these babies, because first thing start how you lift this baby. They are so worried to even lift the baby. The body is so fragile, the head is so fragile. So it starts from even holding the baby, then managing their lines, feeding them. We feed them through a tube which goes from nose into the tummy. So we feeding them. We have to make sure the tube is at right position. It goes into the tummy. So all this
If it's not in the tummy, it's
it
up
will
and
go
you
up.
feed.
Yeah,
it
will
can go in
into
the lungs.
Exactly.
So-
Their
so-
skin is also fragile. If you just touch it, sometimes you see they get abrasion immediately. So we have to be very gentle.
So and just talking of this, I can make out this is such a complex effort, and the entire team it's like that Formula One car comes in, and then the whole team has to
goes
work in unison
to make sure
things happen right. But just tell me, I mean, it must be a difficult task to manage parents' expectations as well, isn't it? It's so. I mean, you mentioned precious is an understatement here.
Yeah.
You're talking of kids.
So I think parents, it's a roller coaster ride for the parents for 3 months, because when baby is born 3 months early, they have to spend those 3 months in the NICU, and hospitals or the ICUs are never the pleasant experience for any parent. So some of my parents have written books, and they've shared their experiences in the NICU. Is definitely not a pleasant one, but we as a team try to make it pleasant. So we talk to them. So that's why even our current NICU MRR is a family centered NICU. So we have even provision for the mothers who sleep there. So because see, we want mother to be there all the time, because the baby feels protected. So we take care of the mother also. So mother sleeps there, and then she can keep producing the milk every 2 hours or 4 hours she can express. Then we allow the parents, there is no restriction for the parents to enter. So our parents enter in the NICU at any time, day or night, whenever they
But
feel
isn't
stressed.
that like nidus for infection? Like, usually the NICU you cordon off.
So we teach them, and we for the very first day we teach them what are the infection control measures. So, and we tell them that the onus is in your hands, so you have to take care. So they automatically follow, washing the hands, changing into gown, because they know they don't want to give infection.
Absolutely, I can imagine that.
Yeah, and then once they stabilize, we put them on mother's shade. So we give like kangaroo mother care. So like in kangaroo has a baby in the pouch and next to the skin. So we do similarly when the babies are stabilized. We ask mothers to come, and inside their gown, the babies can stay. Even if they are ventilated or they are on breathing support, we will put them, and mother can quietly sleep there for 1 or 2 hours, and babies comfortably sleep.
Wow.
I had heard about this kangaroo mother care almost a decade back.
Correct,
At KM, they had started this center.
Yes. I mean, it's a most cost-effective way of also nursing the babies to maintain their temperature. So, and at the origin of that started like in Africa, where they didn't have warmers. So they thought how to maintain the temperature. So they put the babies on the mother's tummy. And then they did everything, and mothers were told to sit in the NICU for 12 hours, just with some breaks. 12 to 16 hours they were in the NICU to maintain that. So, tirelessly they were sitting, and that worked actually wonders. It saved life. So that's how it has become now. We are doing it actively, not only for the temperature control, but it actually helps baby to grow better. They heal faster. Mother's milk output is better. The baby's development is better. They feel like protected, because they feel like they are still inside the tummy, because they can hear mother's voice. They can hear mother's heartbeats. Mother can sing rhymes and all. Garbha sanskar we call. So that can happen. So we ask them to sing, and they can even talk to the babies. Even they are not understanding, but they are listening. So I think this all can be done, and
Superb.
this we try to do that.
Mother, I think, again, as we said, nurses, the other part of the care is the mother, because mother has to express milk. And babies, these babies, correct me if I'm wrong, 2 to 3 hours they require feeding, right?
Correct. Every 2 hours, yeah.
So the mother in the middle of the night also, she's not getting the sleep. She's getting up, expressing milk.
Correct.
Such a turmoil, it's such a turmoil. at that time I think it's the emotional turmoil in the mother which is happening, and that's again one more thing which is not thought of. And I think the hospitals like yours now are thinking in those terms, and that's a big change. That's a big change, because mother also requires to see the baby.
Yeah,
And
yeah.
what happens in a typical NICU is the mother is cordoned off from the
Yes,
baby,
yeah.
because you don't want to get an infection.
No.
Exactly.
So
exactly.
we come to that point then, the whole concept of raising a precious baby should start outside the womb. I mean, it should start in the antenatal period.
Correct.
So if you have a precious pregnancy, I think Kiran More should come in, earlier. He should be counseling, and I think that's the way you do it, right?
Actually, correct. I mean, so what we do is, if suppose somebody is expecting a premature baby, we go and talk to the parents and explain them what they are expecting, what is in there for the next few months, sometimes 2 to 3 months. We prepare them what is going to happen, so that there are no surprises, because a lot of time there's a lot happening when the baby is born, and when they see the baby's got lots of tube inside.
Tubes, I
It's
know,
very
I know.
scary.
Must
It's
be
very
very
scary for the
scary.
parents,
Absolutely,
and mother herself is recovering.
So do you tell them that this might be possible and all? Do you?
Yeah,
do
yeah.
you- but
We
then
actually-
isn't that scary to do? Like you're scaring them before it happens?
No, so yeah, well, no, I think it's important to be prepared,
Right.
because we do give them some steroids. That's a very one sort of intervention which has been very helpful. We give steroids to the mother so that the baby's lungs are a bit more mature, so the babies come out in better shape. So we have to anyway tell them that we are preparing you. There also we give some injections like Maxer to protect the brain. So there are few things we can do, and then team will be prepared, so that there are no so things goes controlled. If there are suddenly babies delivering, there is nothing backup, then baby will suffer. Even that 5 minutes of period where there is no support, baby's brain can actually suffer damage and all those things, and baby can get really sick. So we want it to be a controlled situation, so that's why we talk to them and prepare them.
So ours is like being an interventional radiologist and interventional cardiologist. Ours is a very technology dependent field, like lot of technology. Here, this field I'm sure requires a lot of gadgets for monitoring, but simple measures like kangaroo mother care or
Exactly.
breastfeeding
Yeah,
the
feeding
baby.
baby, yeah.
I mean, this is a very different field, wherein technology and nature, come together.
together,
Yes,
absolutely.
yeah.
And I don't think so till that you will have any whatever parent TPNs you will create, nutritions you will create, nothing can replace
Nothing,
the mother's milk, isn't
Yeah,
it?
no. So I often show that slides, it's like multiple nutrients. None of the formulas have been able to match it, or a TPN able to match the number of nutrients are there in the mother's milk. Nobody has, no pharmaceutical company or nutraceutical company able to match it. So there's no doubt about it. But nowadays, alternative is like there are milk banks which are coming up. So in Wadi also we had, Sion also there is a milk bank. So the mothers who have excessive milk or who are willing to donate, we can pull that milk together and pasteurize it, and can be given it to the mother.
You can't give the cow's milk to the baby.
No, so cow's milk is for the calves, not for our baby.
So how is it different from the?
So the constitution is different, and so it may not be easy to digest, and people just try and dilute it just to match it up to the level, but it's not absolutely. When you dilute it, you dilute the nutritional value as well. So worst case scenario, people have used it, but it's not recommended. Then instead of that, maybe the human formula might be better. Although we don't recommend formula, but there's no need for formula, because every mother will get milk. The process of delivering actually help you to start secreting the milk. So we just have to empower the mother that you will get, and most of the baby, 99% of the mothers are able to successfully breastfeed. Or worst case, if not required, we have a mother's milk bank which can be helpful, but no cow's milk.
What we can make out is you guys have to not just deal with small kids like neonates, mother, the parents, the expectations. So I'm sure with all these things required, the cost of care also must be going higher, isn't it?
Yeah, that's true, and that is where the challenge comes, because unfortunately in India, despite some of the parents having insurance, many insurance companies are not still covering the newborn, because it's an unborn child. It doesn't exist. So the baby doesn't
Are
exist.
insurance companies now covering it?
There
right?
are companies who are covering now. There are like corporate insurance which are covering, and ideally it should cover, because it's a kind of a pregnancy related complication, and you take insurance for the unexpected complication, right? So this kind of complication should be covered, and I think there has to be policy for it. Now Now if there is no insurance, obviously the cost is high, because you want to create a good environment. It comes with its own this thing, so there are a lot of consumables. We use consumables one time, because we reuse them, there's a chance of infection. So there's a single use for a lot of consumables, which the cost goes up. The specialized gadget we use, the machines, ventilators, the breathing machines, the incubators, they all come with a price. A lot of time we have to do a lot of investigation to make sure they are growing well, their blood parameters are accurate, so lots of blood investigation required. And just by sheer of staying in an ICU per day cost, because you need a right amount of nursing care and the doctors round the clock, and it's a 24/7
You
care.
just can't compromise there.
You can't
Just
compromise there,
compromise,
correct.
isn't
And
it?
that's why we try to ensure the nursing ratio. So sick baby should have 1-to-1 nursing, so one nurse
Oh.
completely looking at it. The moment you divide the attention and ask them to look at 5 babies, obviously there are mishaps can happen, cross infection can happen. So there the cost comes up, because manpower, the equipments, gadgets, the space, investigation, all are costly. So although in we try to be very conservative, we try to do minimalist
But
investigation.
I'm sure there must be a lot of social organizations who are helping
Yes.
out, lot
Yes,
of trusts
yes, yes.
who would be helping out, isn't it?
Yeah. So I think I see that there are so many good people in India who are always willing to help, and whenever in such situation we do get help, there are lots of donors who are willing to help these families. So yeah, we have to reach out to them, and obviously we do get help. And then even parents, when I see that when they see the results are happening and they're very positive, then they start also sort of gathering for help and try arrange the funds. But what we try to give them is the good outcome, and what we need is all this effort should end in a good outcome. So baby should survive, not only survive, but also we talk about intact survival. We don't want baby to have any even damage, and that's why you need a good care. So you want baby to go home, but also to do well in life. So that's why you have to protect the brain and protect the baby from infection, protect the lungs, so that the baby's even further course in life is at least good. So that's why we need a good NICU care.
Kiran, just I think for our viewers, one of the main I mean, what do you say, motto of doing such Medicast podcasts is also to sometimes come out with those hidden stories that happen during your process of care for your patient. So do you have some story like that which inspires?
You might have many.
I think
Many. I think every baby might be a story for us.
Absolutely, absolutely.
Yeah,
Sure.
there are many stories, and especially when I was in Wadia, these are very heartwarming stories. People come with so much of hope, and they look up that this is the final destination which we are reaching.
And-
There's nothing beyond.
And that was,
So-
there's so much of pressures of expectation, isn't it?
A lot, and then that's what the pressure is on us, and we try to deliver. And when we get success, everyone is happy. So there are many stories like that. But one
You telling me gives me goosebumps.
I know.
Somebody looking up to you. Yes, the final guy.
Finally, yeah, exactly.
You
There's
have
nothing.
9 months, whole period,
period.
baby inside. They struggling previously also for that 9 months.
Absolutely.
And the baby happens, and then they look up to you because the baby is sick.
And we have nowhere to look up, we have nowhere to send, so we are the final destination kind of thing. But one thing, I mean, from the stories which come out is the positive sort of approach for the parents. So some of the parents don't want to give up, they don't want to they want to give it everything, so many times there are limitations in certain diseases where the physician will feel that, okay, I think we can't do anything beyond and we are going to lose the baby. But there are some parents who don't want to give up, they want to try till the last breath, and I've seen the babies turn around, and they do prove that we are wrong. We know, but many times there are things which are beyond. There's a nature and the God who decides the fate of the baby. So and I've seen it so many times. So one of the story was the guy calling us for referring a child from 1 hour away from our hospital, and the child was very sick. So baby had a severe, we call as PPHN, severe pulmonary pressures, elevated pressures in the lung which were not settling, and despite very advanced ventilatory support, breathing support, and high oxygen, baby were just not saturating, so they were not able to get the baby saturation. Normal is more than 90%. They were just able to reach it around 60-70%. Now they tried for 2-3 days. We gave some advice, but there was not much improvement, and then the sort of a line was drawn that we will lose the baby. There is no more hope, and baby is so sick that baby cannot be transferred in such situation, because 1 hour transferred for that baby in a sick situation, baby will succumb. But father kept trying. He wanted to try and bring it. He said, whatever happens is okay. We will come to you, and if the baby dies, we will accept the fate. But we want to come to you. So obviously we counseled that okay, you would sign the consent that you are accepting the fate, whatever will happen. And he said, yeah, I am happy to sign whatever. And then we sent the team, because we wanted a baby to come in a controlled situation. So obviously we send the team. We tell them what sort of pressures machines should we have. And literally we were constantly talking to the team who was transporting, and baby's saturations never came up above 60% during the whole transport.
My God.
But the heart rate was maintained. Baby was still awake. We gave some medicines, and the team was ready waiting in the casualty, because we knew the sick baby is coming. So the moment baby came, our team was rushing. We straight away rushed the baby to the NICU, and the moment we transferred the baby to the NICU, we sort of did few things to maintain, optimize the breathing and all. And we have this special gas, nitric oxide, which we started, and within like an hour or two, the baby the saturation started improving. We reached 80%, 90%, and suddenly everyone had a hope. And and then we were very positive, and but obviously baby was still in quite sick condition. We didn't know how the fate will be, but there were next 2-3 days when we found few more things on the heart. We did the echo constantly. We monitor this baby had something called as neonatal Kawasaki, which is there are dilatations in the vessels of the heart. He had some other things, and that's why he was not responding. So obviously nitric oxide, we do it for a lot of babies, but this baby was special because there were other associated things. But our cardiology team supported, and slowly baby improved, and we discharged the baby in a good condition. And I saw this baby following up, very charming, chubby, and with a good development. So the whole effort, despite this much of low oxygen levels, the brain was still preserved. Because these babies, they remain in this like fetal state. So this PPHR is like a fetal state. In the tummy, the babies are in at 60-70% saturation. So this baby's brain also managed with that much saturation for over 2 days. So that's why again, the God is great, and that positive hope of that father. He was he was working as a watchman, but he was so positive. He was so positive, and I think that showed the result, and that's why we could be successful, because that strong sort
that
of
energy,
desire,
that energy does flow.
And we see that, right?
We
in
see
our
that,
practice.
In our practice as well,
Yes.
isn't it? Yes.
So what has happened is, over the years, and just going away from neonatology, pardon me for that, but what has happened over the years is the doctor-patient relationship has broken down, in many parts. People ask for percentages.
Yeah.
Guarantees.
Yeah.
See, if you have faith in me, I will do everything
Exactly.
possible. I will move mountains.
Correct.
I will do as if, he's my baby or he's my
Correct.
father,
Yeah.
And that has gone down so very much, and that faith is not remained anymore, And our intention of this podcast is to bring that faith, to bring that
Correct.
hope, where the general population, our viewers, watch this, see our stories, listen to us, see the honesty in which
Absolutely.
way we speak, the way we are treating our patients, and don't ask for percentages from us. These are population statistics.
Correct.
If I say 90%, 10%, you have a 50% chance that you are 10%.
Correct.
You cannot apply it for an individual, right?
Absolutely.
So don't ask statistics. Just have faith in us. Have faith in the doctors that we'll do the right thing.
Absolutely.
Yeah, so I think positive from parents and positive effort from the doctors, then definitely the wonders will be made, and I have seen that happening many times. I'm sure we can share many more stories like this.
I think one thing that I love in talking about the compassion of the doctor and the relationship we are talking right now. One thing I always love is that you are always saying my babies. You're never talking them as patients. You're talking always
correct.
as my babies.
Correct.
And I think that's the lovely
We
part of.
We all do that.
I
right? It's
know.
our
I mean,
patients.
Absolutely.
But-
It's
and
such a
then-
lovely thing to hear always, isn't it?
Yes,
Yeah.
it is, and it's
Correct.
a good note to end, I suppose. Yes. And,
So
thank
parents
you.
hand over the baby in our care, so it becomes my baby till the baby is discharged. So we want to make sure the baby goes home.
So you are
safe.
the guardian of the baby.
Yes, for that time period.
So the neonatologist nurse is the guardian of
Guardian.
the baby in the
Yes.
NICU. Right.
Correct.
Wonderful, wonderful. It was a fantastic podcast. I think through this podcast there'll be a lot of learning for a lot of people.
Absolutely.
A lot of people might be able to take good decisions. So what I think is, one, it's not only delivering the baby. The parent has to think in terms of how the finances are, if there is a problem in terms of insurances and the companies which insure. One, two, decide about the gynecologist. Three is decide about the neonatology team, NICU backup. Four, think about the mother and the mother's issues which can happen. And five, things happen, to take to a hospital like yours, wherein you have a family NICU where the mother has access to the baby. And I think the entire podcast was so much of learning. I'm sure a lot of people will benefit out of it.
Absolutely. And I think it will prepare mentally to so many women would get mentally prepared that if at all something like this happens, this is what I am going to be seeing for next 3 months in my life, and I'm sure you guide them and throughout the entire journey. But I think this will somewhere help at least prepare them mentally about something like that.
Yeah, absolutely.
Thank you, Kiran.
Thank you.
Thank you so much.
for calling.
Thank
Thank you.
you.
Thank you.